name is Jennifer. I am a nurse practitioner who specializes mostly in mental health medication management. With that in mind, I will tell you a little bit about my history. Is that as a baby nurse, when I first graduated from nursing school, I worked in high-risk labor and delivery for about 10 years and knew that there was a piece of mental health that was not being addressed in these patients that were having very complicated pregnancies and sometimes having babies that had medical needs as well. And I kept thinking, we're sending these babies home with these moms that already have medical problems of their own, these babies that may have medical problems of their own, and now we expect them to be able to fully function and not have any difficulties when we have essentially taken away all of their coping mechanisms. You're not getting good sleep anymore. You're not able to eat properly anymore. And perhaps you have a spouse that doesn't understand what's happening. So there's a multitude of things. At any rate, I decided to go back and work on my master's degree in order to blend some of that curiosity with mental health with my background in high-risk labor and delivery. And then I realized that I also had a tremendous interest in continuing to see that mental health, or I'm sorry, the perinatal mental health component. And so I went back and did my certification in perinatal mental health specifically. And especially in learning about women and mental health, I just couldn't ignore the fact that ADHD just kept coming up repetitively. There were so many phases in which ADHD was talked about, and then I would hear, well, it's not really ADHD if they weren't diagnosed before they were 12. And then I would hear, well, yeah, I mean, I guess they could have symptoms, but it's not really ADHD. It's anxiety, or it's depression, or it's a multitude of other diagnoses. And the curiosity in that really made me decide to do some more investigation. And I had a fantastic mentor who also shared lots of her learning as well. So I am a med provider, and I can write prescriptions within the entire realm of psychopharmacology, including controlled substances, stimulants for ADHD, and even specialized anxiety medications. So the goal of the presentation today is to enhance the understanding of gender differences in this presentation and management of ADHD to enable healthcare professionals to deliver gender-sensitive and effective care for all patients, regardless of assigned sex at birth. Just globally speaking, the objectives will be to understand gender differences in the presentation of ADHD, including both assigned female at birth and those assigned male at birth, and explain the biological, psychological, and social factors which contribute to these differences. And then we'll also talk about managing the differences in ADHD across the lifespan and what that means during different phases, especially with regard to assigned female at birth. And I apologize when I say women, I do always mean assigned female at birth, because I do not ever want to be not inclusive, so that's very important to me. Although I do very much slip up sometimes. So, and also want to examine the role of the comorbid conditions that exist. There are a variety of parts of our brain that are impacted by ADHD. And that definition at the very top from the American Psychiatric Association is the literal definition from the DSM criteria. However, with that being said, there are 4 main parts of our brain that are impacted by ADHD. And you don't have to remember this, but just to know that there are 4 very specific places. The prefrontal cortex, our limbic system, the basal ganglia, and the brainstem. So again, you don't have to remember that, but beyond that, there are 3 chemicals or neurotransmitters that are involved in ADHD. So the first one is dopamine, and oftentimes we hear about dopamine in response to reward, our reward pathway. But it's also involved in regulation of our mood. It's involved in pleasure. It's involved in our sense of motivation and attention. Then we have norepinephrine, or sometimes people call that noradrenaline, which is part of being alert, being motivated, having attention, and it's also involved in our sleep cycles. So, and lastly, one that doesn't get talked about quite as much is serotonin. So serotonin is involved to a lesser extent in ADHD. However, it has a valuable role for sure. So serotonin is generally the hormone or the neurotransmitter that we think about with respect to overall mood. When we think about medications for mental health, oftentimes we think about the SSRIs. So those are the medications like Prozac and Zoloft and Celexa and Lexapro. All of those medications really they will impact serotonin. And we'll talk a little bit more about that in here shortly, but essentially that's the very first line that we think about with respect to mood regulation is with serotonin, but it's also part of ADHD. In terms of the way that ADHD presents in females or those assigned female at birth, we look for more internalized symptoms. So those are things like daydreaming, or they're staring out the window and counting the red cars that are in the parking lot, as opposed to being disruptive. We think about, the media portrayal of ADHD has always looked like the little boy who's really bouncing off the walls and being disruptive and getting sent to the principal's office. And in reality, that's an externalized presentation of ADHD, but females and those assigned female at birth tend to have more of internalized symptoms. That emotional dysregulation that they're feeling, that busy brain that's happening, is not being loud in the classroom. It's not disrupting anything that's happening. It is still feeling inattentive. They're not necessarily able to pay attention to what is happening. They are often disorganized, but appear organized on the surface. So that's really an important distinction, because oftentimes I will hear someone say, well, but they're doing really well in school. Okay, think about what could be happening. What is the expectation from a media and society perspective about what girls are expected to do? Girls are expected to be seen and not heard. They are expected to hold everything together, and but in reality, they are more likely to be diagnosed with anxiety, depression, eating disorders, and sometimes one of the first presentations that we see is even with self-harm or suicidal behavior. That self-harm is part of the impulsivity component of ADHD. There is a drive to try to figure out exactly how they can regulate all of these thoughts that are happening in their brains in this very, very busy brain, but they don't have the tools in which to be able to do that. And self-harm and sometimes even suicidal behavior or suicidal ideation tends to be the way in which they're like, okay, well, this will solve my problems. This will make me feel better. And I've actually had, I think, probably 3 or 4 female presentations, girls that identify as female, have come into the office and said, their moms and dads have said they're self-harming out of the blue. We're not sure where this came from, why it happened. And when we do a little bit more investigation, I find out that they started their period 6 months ago. Or they are, getting into middle school, and girls will tend to mask or cope for a very long time before they will start to give you indications that something is not going well in their lives. So that next, coping strategies and masking, they are more likely to compensate to mask symptoms, and that often leads to delayed diagnosis, misdiagnoses, and often underdiagnoses. So I've had several females that have also been diagnosed as being bipolar. And when we really flush that out a little bit further, we discover that what has looked like risky behavior or has looked like manic behavior is actually impulsivity. That doesn't necessarily meet the criteria as being risky, but is often more like I was talking about the self-harm. Is that a risky behavior? Yes, it is a risky behavior, but is it something that happens in a predictable pattern that actually fits the criteria for bipolar? Oftentimes not. The next piece is hormonal influences, and we know that there's a fluctuation in presentation based on hormonal changes. So some of the most frequent times that we see those assigned female at birth diagnosed are during adolescence, right around the time that they first start their periods. We also see pregnancy and postpartum diagnoses and during menopause, interestingly. So we know that estrogen enhances the activity of dopamine, and there's a strong impact of dopamine synthesis and a decrease in dopamine reuptake related to estrogen. And we'll talk about that more in a second. Dopamine is one of those neurotransmitters or hormones that is related to ADHD diagnoses. Dopamine function in the prefrontal cortex is essential for executive functioning and working memory. So if your estrogen levels are low and your dopamine levels are low, then you're also going to have difficulty with executive functioning and working memory. You also will recognize that there are some social, occupational, and relational impacts that happen. There are noticeable differences in acquisition of friendships, maintaining relationships, and social interactions that are more challenging for females or those assigned female at birth. And they are more likely to experience greater stress in social interactions related to shame, a perception of failure, and having low self-esteem. The impacts of different hormonal times, especially the luteal phase of our cycles, that may necessitate changes or differences in medication management. So this next slide, for those of you who know a ton about OB and are watching this presentation, I'm going to be very simplistic, but essentially the first line is indication, and for those of you that don't have the presentation in front of you, there is what is called the follicular phase of our cycle, which begins the day that our period starts and goes to ovulation. And that period of time is about 14 days in a 28-day cycle. But during that time, we get a general increase in estrogen over that time period, which spikes about a day before ovulation occurs. And with that increase in estrogen, we get more action from dopamine and serotonin as well during that time. So estrogen starts to go up in anticipation of ovulation, and we get more action from dopamine and serotonin. So then ovulation happens and estrogen levels dramatically decrease about a day or so afterwards. And during that time, women often will say that they can feel that hormonal change happening, and they will feel less motivated, they'll feel tired, they will feel less focused, they will have a lot more difficulties with their ADHD symptoms, executive functioning. And there's a little bit of a rebound in the estrogen cycle during that luteal phase, the luteal phase begins from ovulation until the beginning of the next period. But that's when your lining of your uterus is building up in anticipation of a fertilized egg implanting. And when it's not fertilized, we get a sharp decrease in estrogen again, and the next period happens. Well, with estrogen being tied to dopamine and serotonin, we know that sometimes it benefits women to be able to take a slightly larger dose of something that supports their serotonin. So maybe Prozac, maybe the medication that they've been taking for their depression is Prozac. They've been taking 10 milligrams for their entire lives. For as long as they've been taking meds, they've been taking 10 milligrams. Sometimes if we boost that amount from ovulation all the way through the beginning of their next cycle, so that they take 10 milligrams in the beginning of their cycle and 15 milligrams during that second half until their next period begins, that sometimes shores up those depressive symptoms. It helps to support mood. But the other thing that can happen is sometimes the dopamine levels are so low that sometimes we actually increase the amount of dopamine supporting medication during that time. Most often that is a stimulant medication. It does not have to be a stimulant medication, but most often that is the most effective type of medication to use during that time. You're looking at things like Prozac and Zoloft and the SSRIs for sure, but then also sometimes the SNRIs can be beneficial as well. So it just depends on what they are already using that works. And sometimes we just need to boost it a tiny, tiny bit in order to support their mood during that period of time until the next period starts. I usually try to do the antidepressant first. We try that first to see if that works. If that does not work, which it sometimes doesn't, then we do sometimes boost or even give like a tiny little booster dose of medication just during those days. Is how does this all work in the context of birth control? So you have birth controls that are considered combination birth controls. So you have some that provide both estrogen and progesterone. Then you have some that are only progesterone medications. So things that are only progesterone medications are things like the all of the IUDs are progesterone only. So the Kylena, the Skyla, the Mirena. Then you've got things like Nexplanon, which is also only progesterone. And unfortunately, progesterone increases systemic across your entire body. Increases in progesterone lead to increased anxiety and depression symptoms. So sometimes those systemic medications are not ideal for people who already have difficulties with depression and anxiety. And in the combination birth control pills that are systemic, where you're taking a birth control pill every day, goes into every cell of your body, those medications often do okay for people who have ADHD. Not fantastic, but they're better than progesterone only systemic medications in terms of mood regulation. So, and then you've got things like the IUD, which that is considered localized hormone, where you're only getting the hormone effect at the level of the uterus. In theory, the IUD should not be giving a large amount of progesterone across your entire body. It should only be at the level of the uterus, which is where it works. Those oftentimes help from the perspective of you don't get bleeding, but you still, even in the presence of those hormonal birth controls, you still have this general pattern occurring in the background. You still get this rise in estrogen. You still get a rise in progesterone at all of those times. It's just there's also the added component that helps to prevent pregnancies. And we could go much deeper into that if you guys want to, but I would always recommend that if there's a lot of questions about this, I direct people back to their OBs, and I will certainly collaborate with them and talk about the best options, because sometimes what works for one person doesn't work for someone else, but that doesn't mean that, we should mark anything off of the list. So presentation of ADHD symptoms in patients that are assigned male at birth, those, I sort of touched on this already, but they tend to be the more externalized symptoms. Because they're externalized and because they're things that you see with your very own eyes, those tend to be more noticeable. And so therefore, those assigned male at birth are often diagnosed earlier. They tend to experience more academic challenges, including academic success. They have difficulty following directions, maintaining focus, and that gets perceived as a lack of effort or a laziness. They also have difficulty later on maintaining steady employment status, and that can also be related to difficulty with authority figures, or greater likelihood of needing disciplinary action because of some of those externalized behaviors. So there's also a greater likelihood for engagement in substance use and risk-taking behaviors, which sometimes get diagnosed as oppositional defiant disorder or conduct disorder, which may ultimately lead to greater likelihood to be involved in the legal system. So social interactions tend to be that their peers oftentimes view them as annoying or intrusive, or their hyperactive and impulsive behavior will lead them to being isolated or even bullied in school. So, but they're less likely to report these difficulties because, again, going back to what society finds acceptable, they don't want to be the tattlers, they don't want to be the ones that are bringing attention to the fact that they're having a difficult time. So sometimes they just end up becoming more outwardly presenting in terms of their symptoms. Biological factors, we know that those assigned male at birth have a smaller volume and have delayed development of their prefrontal cortex. So prefrontal cortex is where our executive functionings ultimately happen, and that tends to translate into more frequent presentations of impulsive and hyperactive behaviors. I like to think about this in the context of 18-year-old riding down the highway, doing a wheelie on his motorcycle with no helmet. Okay, at 18, your prefrontal cortex is not well developed. It's trying to develop, but they're doing things without necessarily thinking about the consequences of that behavior, because their response is they want to get an immediate thrill. They want to feel an immediate benefit from what they're doing, and doing a wheelie at 60 miles an hour down the highway is certainly going to lead to a dopamine response. They're going to get a bunch of dopamine release, and that's going to feel positive to them. And they have thus self-medicated. So then there's also a dysregulation within the norepinephrine and dopamine systems, which may contribute to more pronounced ADHD symptom presentation. Kind of again, what we were talking about with sometimes when kids are, those assigned male at birth, are isolated or become ostracized by their peers, sometimes their presentation of symptoms get worse because negative attention is better than no attention at all. They look like the kids who don't want to follow the rules. They tend to look like the kids in class that don't necessarily want to be viewed as paying attention to the teacher or being respectful. They tend to be the kids that look disrespectful and unkind, but really they're just trying to make themselves feel better. The class clown. There's also a hypothesis that elevated levels of testosterone in patients that are assigned male at birth may lead to the development of hyperactive and impulsive presentation symptoms. And we can certainly talk about that more, but I think that's also important to talk about in the context of those that are transitioning from assigned female at birth to male. When you add on that component of testosterone, then we tend to see more presentation of hyperactive and impulsive symptom presentation. So there's also fluctuations in estrogen and progesterone throughout the lives of those that are assigned female at birth, and those may intensify signs of inattentiveness and emotional dysregulation. We talked a little bit about the internalizing behaviors versus externalizing behaviors, and then there's also the psychological factor related to self-esteem versus self-perception, how we see ourselves, and the type, how much self-esteem we have, and pride we have in who we are. So patients that are assigned female at birth often experience pressure from society to conform and to do the acceptable things, which lead them to hide their presentation of symptoms, and thus those internalized symptoms get interpreted as other mental health diagnoses. It's not uncommon to see anxiety and depression and bipolar diagnoses come through. And when we really start to parse it out and have a bigger conversation, we realize that while those things may be present, there's also oftentimes ADHD that's it is in the background too. So patients that are assigned male at birth are more likely to outwardly present their ADHD symptoms, which get noticed and get responded to more quickly by their peers, by teachers, by parents. And this early intervention shapes their perception of themselves and sometimes even reinforces the disruptive behaviors. So there is differences in emotional regulation. So patients that are assigned male at birth are more likely to exhibit obvious emotional dysregulation, whereas females or those assigned female at birth tend to demonstrate mood fluctuations and be experienced as sensitive. Or, oh, just, pull it together. That's oftentimes I hear people say, I don't understand why she just pull it all together? What's wrong? So there are also social factors. So there are females or those assigned female at birth are expected to follow the rules and present themselves as reserved, whereas assigned male at birth are expected to be more physically active and we're more accepting of the fact that they don't comply with rules or they don't follow the expectations that we have of those assigned female at birth. They are natural leaders. They are also, those assigned female at birth also tend to be the perfectionists. They hold very high expectations for themselves. They are those that succeed even in the face of having to push really hard or try twice as hard as their peers to be just as successful. And that leads to expectations that they continue to maintain that. But as they get older, it becomes harder and harder for them to be able to mask and cope. So if you think about the obligations that an elementary school student has, a female in elementary school goes to school, has their friends, and things aren't generally noticed during elementary school. Then they get to middle school, and for many of them, their periods start, and then they have all of these social constructs or expectations that are happening where they're needing to perform in a specific way, or they're needing to fit into a nice tidy box of wearing certain outfits and doing certain things in order to be acceptable. And it becomes harder and harder to mask those symptoms and that emotional dysregulation that's happening inside. And then you get to high school and the stakes are even higher. And so now you've got these hormonal fluctuations that are happening because periods have started. You've got all of these social pieces. And now you've got the expectations of, okay, you've got to do well because you've got to get into college. And it's becoming harder and harder for them to be able to mask these symptoms. There's the whole component of it's not interesting. It's not necessarily fun to be able to sit down and do a homework assignment that you have no interest in. And so it gets pushed off and then they look like procrastinators, or their parents start to get upset and say, well, they're just being lazy. No, they're not being lazy. They're actually having a difficult time initiating because the task is not a preferred task. Socializing as a patient who's assigned female at birth can lead to loneliness, can lead to withdrawal from social situations or groups. And we know that those assigned male at birth are often rejected by peers, or their impulsive and hyperactive behaviors become prominent to the point that they're withdrawn, rejected, ostracized. So these ADHD symptoms during significant life transitions. And so during childhood to adolescence, we see those assigned male at birth as being hyperactive, impulsive. They have difficulty completing assignments. They have lower grades. They tend to have poor organization skills. And those assigned female at birth tend to be forgetful and daydreaming. They often look unmotivated or lazy. They have mood swings with increased anxiety and depressive symptoms, sometimes social withdrawal. Then from adolescence to adulthood, males or those assigned male at birth tend to do more risky things. They start using substances to try to regulate their brains. They have difficulty forming friendships and romantic relationships, which may ultimately lead to low self-esteem and rejection by their peers. Then those that are assigned female at birth tend to have difficulty meeting due dates. They have a difficulty with organization. They have intensified academic expectations, which end up leading to low self-esteem or low self-perception because they can't meet those high standards that they have for themselves, because the motivations become difficult or they feel like they don't fit in. And then in adulthood, those assigned male at birth tend to have difficulty with time management. They have difficulty with being attentive and focusing on career advancement, which sometimes impacts financial security, or sometimes their partners interpret that they don't care or that they're not going to work hard to get to the next place in their careers in order to provide financial stability for their families. And it isn't always necessarily related to being unmotivated or any of those things. It's just fear of not being successful or fear of failure. So, and then as a parent and as a partner, they look impulsive, they look disorganized, they have a low amount of patience within the family unit. They tend to be the dads who lose, or the male partners who lose their patience, or yell and scream or present as angry. And it's not because they are necessarily angry as much as it is they feel a lack of control or difficulty managing their circumstances. And then females, or those assigned female at birth, tend to have hormonal changes that continue to impact emotional regulation, anxiety, and inattentiveness, but they have increased feelings of stress. They describe themselves as overwhelmed. And they're trying to fill all of these roles and feel like they can't do any of them well. Specifically related to women, hormones, and ADHD, that's actually the title of a presentation. So, and the link is at the bottom of the slide. With at the onset of puberty, estrogen and progesterone levels increase, and ADHD symptoms may become more pronounced. And oftentimes existing ADHD medications or those for anxiety and depression tend to become less effective. So sometimes we just need to modify the dosing. Then we know that PMS, which we've often all heard of, those of us that have periods, but there's also, so premenstrual syndrome is sort of that decrease in dopamine that happens. You start craving things like sugars, or you are craving chocolate, or you're craving simple sugars like those in carbs. And that is often a direct result of the fact that you need more dopamine. And when you eat carbs or simple sugars, that's going to release dopamine into your body and thus make you feel better. However, in women and those assigned female at birth that have ADHD, there is something called PMDD, which is much more common, which is premenstrual dysphoric disorder. And that is, the best description is like PMS on steroids. It is incredible mood shifts. It is very dramatic changes that happen in mood, in which women and those who are assigned female at birth are 4 times, maybe even 5 times more likely to experience PMDD symptoms than those of the neurotypical. So then we also see that during pregnancy and the postpartum period, there's a hormonal shift at the beginning of pregnancy, which may lead to some mood swings. But in general, estrogen is pretty steady during this time, and ADHD symptoms and mood symptoms often stabilize during this time because you're not getting those dramatic changes in progesterone and estrogen that are happening during normal menstrual cycles. It's stable while you're pregnant. So, but then in the postpartum period, there's a sharp change in hormones again, which will again lead to mood swings, postpartum anxiety, and postpartum depression. So that is another time that is pretty common for women to be diagnosed with ADHD, because those symptoms become so prominent during that time. And when we really flush out exactly what's happening, we notice that there's ADHD presentation. In the approximately 10 years before menopause begins, there is large changes that happen with estrogen and progesterone, and they drop roughly 65%, and then eventually periods stop. And in women with ADHD, this can lead to dramatic mood swings, tearfulness, sadness, irritability, brain fog, and worsened memory. So that's another, these are four big times in which ADHD is often diagnosed in those assigned female at birth. So, in terms of comorbid conditions or other things that commonly occur with ADHD, we know that anxiety is more commonly diagnosed in those that are assigned female at birth, and they worsen ADHD symptom presentation. We know that there is a greater prevalence of depression in those assigned female at birth than those assigned male at birth, and that oftentimes necessitates thoughts about antidepressants or something to help regulate mood. Eating disorders are also more prevalent in patients that are assigned female at birth and can complicate medication management of ADHD, along with requiring a multidisciplinary approach to treatment. Sometimes in a world in which those assigned female at birth feel that their brain is going in 1,000 different directions, the one thing that they can control is how much food they put in their body or how they get rid of the food that they have overindulged in. So you'll see anorexia, you'll see binge eating, and it's all about, I wouldn't say all, it is largely about the ability to control some aspect of their lives in something in a time that feels otherwise out of control. So we have conduct disorder and oppositional defiant disorder, which is more prevalent in those assigned male at birth and may require interventions that focus on behavior modifications and management. And substance use disorders are more common in those assigned male at birth, but may require integration of other services. There was actually a study, and I meant to include this, but there was a study that was done that looked at substance use disorders in the incarcerated population, and one of the discoveries that they had is that the substance use disorders were common, although there was a large number of those that were incarcerated that actually had undiagnosed ADHD. There's this component of trying to medicate away the symptoms that you're experiencing, and oftentimes it shows up as substance use disorder, especially use of stimulants. When I hear people come in and tell me that they have historically utilized cocaine, I will ask them, what was your experience with using cocaine? How did you feel? And oftentimes I will get, all my friends, were sort of off the wall, and I just felt like it brought me into normal. It just made me function like my brain felt like it was working correctly. I felt like I was able to have conversations and engage socially. But then I liked it too much. And I'm like, yeah, you liked it because it made you feel normal for the first time, or what, quote unquote, whatever normal is supposed to be. So, learning disabilities, there's an equal prevalence of learning disabilities in both those assigned male at birth and female, but they're more often diagnosed in those assigned male at birth because they have the overt presentation of ADHD and they're often diagnosed sooner. Sleep disorders has become a really hot topic. It's common in both genders, however, it can be exacerbated in ADHD symptom presentation. You'll hear about sleep procrastination, and we could go on and on about all of these topics, but there's a lot of talk about sleep and relationship to ADHD. Some interesting facts and statistics about ADHD just in general. So there's worldwide, depending on the data source, young patients that are assigned male at birth are 2.5 to 7 times more likely to be diagnosed with ADHD than their assigned female at birth counterparts, although rates are similar in adult men and women. So the average age of diagnosis is 7 years old, with children living in homes where English is the primary language, being 4 times likely to be diagnosed. ADHD is largely genetic, 8 times as likely to be diagnosed with ADHD if you have a sibling that has been diagnosed, And when we study twins, the genetic contribution to ADHD is believed to be as high as 76%. And I will speak from personal experience. I have um, a female or assigned female at birth and a assigned male at birth. They're twins and they both have ADHD. So, but the presentation between the two of them was incredibly different. So I saw it with my own eyes, which was another reason why it became a very interesting subject for me. However, when the world's largest genetic data set of individuals with and without ADHD, approximately 55,000 people were examined. There was commonly occurring genetic factors, and the findings revealed no significant differences between males and females, or those assigned male and those assigned female at birth. Thus, the same genetic factors are relevant in both groups. While I do certainly see a fair amount of grief in these patients' experiences, I also see a sense of relief, like, oh, this all makes sense. And when they look back, if we talk about their history, one of the questions I always ask my patients is, describe yourself as a student. What was your experience like when you were in elementary school all the way up through college? How did you present to, did you have a lot of friends? And I try to get them to talk about that because it also helps them to make a connection between, oh my goodness, this has been going on for a really, really long time and I was just really good at hiding it. Or they start to say, oh my God, I see this in my mom, or I see this in my dad. And I think that also helps to know that they're part of something much bigger that just wasn't noticed for a very long time. And I also try to share the fact that women didn't become, or those assigned female at birth, didn't become part of the research for ADHD until the late 1990s. So we have a very short period of time which those born female have been included and talked about, and the hormonal components to this. Yeah, as much as it is about grief, it's also a lot about relief. Like, oh my gosh, now I know why I feel like I turn into this person I don't recognize about 5 days before my period starts. This makes sense. Or I can't remember a single thing. I forgot to feed the dogs and I felt awful about it. And it was like, it makes sense. Ultimately, sometimes I will have patients who will say, but I'm 45 years old. Why should I be medicated now? Yeah. And to that, I usually say, if you feel like you're in a place that knowing that ADHD is present in your life, and you decide that, you know what, I've got plenty of tools. I figured out coping mechanisms. I'm good. That's okay. You don't have to medicate. Sometimes just having the diagnosis and knowing that it's something that's been there for a while gives you permission to say, yeah, I haven't been perfect, and that's okay. Like, I did the best I could with what I could do at the time. And nobody intentionally, I think that's another piece, is sometimes people will say, but my parents missed it, or my parents decided not to treat it. And I always caution people about being too upset about that more, and say, you know what, ADHD was not really something that we talked about in this context even 10 years ago. And so, not that it makes it okay that you dealt with this, but it also gives some context about, now that we know better, we can do better. We just really touched on the very, very top of these subjects. This was designed to be educational, although certainly not all inclusive.